So let's talk about some of those cranial nerves monitoring. So cranial nerve monitoring, intraoperative monitoring of cranial nerves 3, 4, and 6, which are not as common as the other one, 5 to 12, which are routinely monitored. These cranial nerves are more difficult to monitor and need more training. So it's very, very important that we should be, whoever is doing that, need training and how to place the electrode, because these electrodes are placed next to the eyeball and the muscle of the eye. And so we are using oculomotor. You can see then these nerves exiting the brainstem. Three for oculomotor, trochlear, and abducent nerve, 3, 4, and 6. So so these are not commonly performed, and so there's a high risk of damage to these nerve in these procedures. So um, they should be monitored, but the training is very, very important. That you can do EMG, trigger EMG, and many people have tried to do MEP as well. So oculomotor nerve is a cranial number 3. It leaves the midbrain and anterior surface, and it divides into superior and inferior rami and exit the cranial cavity through superior orbital fissure. These rami innervates the muscle levator palpebrae superioris in the eyelid, superior oblique muscles, inferior oblique muscle, inferior oblique muscle, superior rectus muscle, medial rectus, inferior rectus muscle. So there are 6 muscles of the eyeball: superior rectus, inferior rectus, medial and the lateral rectus, and superior oblique and inferior oblique. So 4 of those 6 muscles are supplied by the oculomotor nerve. It's a motor branch. So superior rectus, inferior rectus, medial rectus, and superior and so and inferior oblique. So those are the 4 muscles supplied. So the trochlear nerve, the fourth nerve, is only cranial nerve that decussates. So it decussates to the other side. The nucleus is located caudal to the oculomotor nucleus at the lower midbrain. The trochlear nerve axons exiting from the nucleus cross within the midbrain and then exit on the contralateral midbrain dorsal surface. It curves forward between the posterior cerebral and superior cerebral arteries and lateral to the oculomotor nerve. It continues through the middle fossa and the lateral wall of the cavernous sinus. It exits the cranial cavity into the orbital cavity through the superior orbital fissure, and it innervates the superior oblique, only one muscle, superior oblique muscle. Cranial number 6, abduction lies within the dorsomedial level of the caudal pons, and axons project through the pons and emerge as nerve at the pontomedullary fissures. It supplies only one nerve muscle, which is lateral rectus muscle. So the modalities we can oculomotor nerve, all these nerves we can do spontaneous trigger EMG and motor MEP as well. So if you look at the cranial nerve number 3, oculomotor, the function is eyeball movement. It moves the eye upward, inward, downward, and outward. The intraoperative EMGs we can monitor for placing electrode in superior rectus, medial rectus, inferior rectus, or inferior oblique. The trochlear nerve originates in small nucleus, as we mentioned. The trochlear nerve function is eyeball movement downward and lateral. So it supplies the superior oblique muscle. So we can place electrode in superior oblique, and if there's a damage to this muscle, patient will not be able to move downward and lateral. So patient eye will be inward and medial. 6 cranial nerves. It's lateral rectus, so when it contracts, it moves the eye by outward. So if that nerve, 6th cranial nerve, is damaged, then the eye will be deviated on that side toward inward. So these are the 6 muscles, the oculomotor and nerves supplying medial rectus, superior rectus, inferior rectus, and inferior oblique. Trochlear nerve 4 supplies superior rectus, and abducens nerve 6 supply the lateral rectus. These are all known as extraocular muscles. So 90-degree needles are shown in these pictures. So these are the ideal electrodes. So you should not be placing straight needle because they are up in the air. So use 90-degree needles. And it's recommended not to bend the needle because bending needle may cause breakage by most of the manufacturers. They don't recommend. But we already have in the market different manufacturers which make electrode which are already 90-degree or 30-degree bend. So if you have pair electrode, that's ideal. So you have high specificity, but you can also use monopole electrode, and then the reference electrode can be used on the opposite side above on the forehead. So the best recording, which has the lowest impedance, and it also has it doesn't pick up far field responses, is paired hook wire EMG electrode. So these are very small electrode which need a needle to insert and have very small hook on it. So they are always recommended for all these cranial nerve monitoring for all the facial, including facial nerve and these nerve. These electrodes are placed percutaneously and the muscles around it. So we can do referential recording and bipolar recording. Referential recording is more sensitive. Bipolar recording is less sensitive but more specific. They have different papers if you want to read about them. They talk about the stimulation, the recording technique, and the stimulation intensity, and the frequency of stimulation, and the duration of the microsecond, how many. The different type of surgeries where we can monitor these cases are cavernous sinus tumors, prepontine tumors, clival tumors, ophthalmic aneurysm, and the frontal lobe tumors or mid-fossa tumors can be important to do that. So this is another paper published about use of cranial 346 during trigeminal schwannoma surgery. This is one of the patient who have trigeminal schwannoma on the left side, and you can see. So these are the electrode. We place the electrode for cranial 3 medial rectus here, superior oblique, and then lateral rectus and the inferior rectus. So those are the 4 paired electrode we use that. And these are the train activity which was recorded from cranial 3. The clinical tests, I'm not going into detail about clinical tests, but classic eye exam is H test, which is very easy. It takes less than 10 seconds to do that. Move your hand up, down, left, right, and that will help you to monitor cranial 3, 6, and 4 for the left side and right side.